Okay, osteogenesis imperfecta is a big question, and it's ever lasting, changing process. So I will try to cover upper, lower extremity, give some tips and tricks, talk about complications and take-home points. So state of the art is intramedullary fixation, correct deformity, restored extremity function, and individualized physical therapy. Plates and screws are out. Because there are many problems, some new devices are invented, like a slim nail or a gap nail, and plate and screws are really rarely indicated and should be avoided, as you can see on this slide. Solid intramedullary rodding is introduced a long time ago by Soffeld and Miller, but still are used somewhere in some countries. And you can see the complication of solid intramedullary rods are quite frequent, but immediate benefit is obvious, especially if surgeon understands the principles. So dual rush rodding is quite popular, as I heard, especially in India. And telescoping rods are trying to solve the problem of outgrowing the solid nail, and they are introduced in the United States in '63, and first generation is called Bailey-Dubov telescoping nails. Second generation comes from UK, Sheffield, as a previous speaker, and they are also still popular, I think, in some parts of the world. And there are quite a lot of literature on even long-term results on. But in 2001, on a Poznan meeting, there was introduction of fascia Duval nail, which is currently very popular, as you can see from the booth in exhibition section. In many countries is used, and more than several dozen thousands of nails are already applied. And this is the paper from 2001, and you can see most of you are familiar with this slide, and some indication are listed on the slide. There is no need for ankle or knee arthrotomy. Two components are screwed onto both bone ends, and you can utilize open or percutaneous osteotomy. You need, of course, X-ray and very good radiologic technicians to help you if you want to do that quickly and efficiently. Also, there is interlocking nail, which was introduced by Dr. Cho from South Korea, and it is also well known from the literature. This is one newest article regarding this interlocking nails, especially in tibia. And the difference between Bailey-Dubov or Sheffield and fascia Duval or interlocking is listed on a slide. It's regarding to arthrotomy, especially in the ankle joint, is not very pleasant to do arthrotomy. So indications are listed here. Bone should be of adequate quality to support the rod, progressive bowing and sufficient severity, which interfere with ambulation. Ankle, which is formed in the plane of knee and ankle, approaches more than 25 degrees, and if the patient has two fractures on the same bone, long bone in 1 year. Regular nail or solid nail are cheaper, easier to insert, but need to be replaced regularly, but telescoping are more expensive, more difficult to insert, and there is a question if there are fewer reoperations. In upper extremity, usually we do 10% of surgery in upper extremity. More surgery is done on lower extremity due to impaired ambulation, and in upper extremity deformity is better tolerated because of possibility of rotation in the shoulder. And here you can see some deformity in upper extremity, but our indications are improve the function, prevent the fracture, correct deformity, decrease the pain, and there are some reports from the literature. You can see even in early 2000s, people used to operate on upper extremity. Some cases could be treated conservatively. Not every case should be operated. But on the other hand, some other cases can produce, if you treat them conservatively, quite significant deformity, and surgery will be necessary later on. And here you can see what we do in our hospital, fascia dival in both humerus. And recently we introduced this female type or holotype from the elbow, because it's easier and it's not so difficult to find the hole for insertion as in proximal part of humerus. Some experience come from Canada and United States, where they have a lot of patients, and results are quite similar, as you can see in this summary of those slides. And what is important to have a very good functional outcome, and that's the reason for the surgery, but mostly you operate on a patient of type 3 and type 4. As you can see, none of the patient is of type 1, and type 5, only 3 patients are operated in Montreal. Here is one patient which has a forearm deformity, and if we operate, we first start with radius. If we start with ulna, then it's very difficult because of rotation to correct the radius. So take-home points for the upper extremity. This is not only cosmetic problem, it's also functional problem. We want to prevent the fracture because there is a vicious cycle, correct deformity, and more and more often surgery is performed in upper extremity. But every patient is different, and even every bone is different in those patients. In lower extremity, we have tibia. Tibia somehow I consider this as a problem bone. I will explain that. Why? Because the space intramedullary is narrower. Total weight bearing is much more applied on tibia in comparison with femur. There is a lot of a lot of other problems like muscles, which are quite strong, and fibula is preventing the full correction in some examples. And the walking is more difficult if you have angulation procurvatum of 25 degrees. If you have 25 degrees in femur, you will walk like a waddle walking, but in tibia you just cannot walk. So also there are other intramedullary problems as with sclerotic intramedullary canal, triangular shape, and in the distal tibia you don't have enough bone for purchase, and so this is our results. We noted quite a lot of complications, mainly protrusion of intramedullary implant, even distally and proximally, and usually you need reintervention or revision. And this is one solution to solve the problem with interlocking. Sometimes you can put interlocking nail. This is just to show that this tip shouldn't be protruding. You should cut it off. And here, if you have protrusion in the ankle joint, you can stop it with a K-wire, because once when there is protrusion, it will go and go. Here you can see the isthmus, which is very problematic, and it should be reamed quite well. Otherwise, you will push the intramedullary nail into the ankle joint, and then you have a permanent problem. We also use interlocking, as you can see here. And there is quite a question if third generation has a less revision rate. And it seems that according to this study, there is quite a lot of revisions. As you can see here, 40%. And also you have problems with tibia because of bending, as you can see the problem here. Then you need a rescue set. And one example from our hospital where we perform a revision with quite good results. And here you can see the preoperative and postoperative and the clinical status and most recent photo of this patient. Another tibial case is shown here, previously operated with solid nails. Quite a huge deformity. Every tibia is different, as you can see. Almost another knee in the tibia on this clinical photo, and X-ray results immediately post-operatively, and later on you can see the patient is on this photo sitting, but can walk now with some help of crutches. And another case which shows sclerotic canal. So the take-home points in tibia, this is a problem bone, and one should be quite aware of the possible problems which you can be confronted when you work on tibia. And successful correction is possible. The patients agreed even for the multiple corrective surgery because they can be able to walk. So now we have a lack of time to cover the femur. Maybe I should just show you several X-ray, which I think are important. Here you can see the problems with femur. If the patient is treated for prolonged pamidronide therapy without operation, a patient has a sclerosis in the canal and quite a significant deformity. And here you can see the false coxavara, just to remind you on this problem. Greater trochanter is posterior. One should be aware of this. Again, coxavara, false coxavara. And here, if you don't ream the sclerotic part extensively, you can end up with, as is it shown here, you can end up outside the bone. And so this part is quite important. So, again, you have a problem with the soft tissue, which sometimes is necessary to release. Otherwise, you cannot correct. Or you have to shorten the femur with trapezoid bone wedge. So the future is in research is goal to convert severe OI to the milder one. And in surgery, we are waiting for the next fourth generation of intramedullary nails. And I think I will stop here because